So with that, I think apropos of today's M&M, talking about older patients that we're all seeing for a variety of things, and certainly the tragic patient, the young patient, but tremendously ill, raises important questions about how we think about frailty and futility. And looking forward to Dr. Romanowski updating us on this really important topic. So thank you.
Thank you. All right, can everyone hear me? Yeah. Great, thank you. So yeah, I also want to thank Dr. Mel and Dr. McVicker for choosing cases leading into this Grand Rounds talk that illustrate exactly what I'm talking about. One elderly patient and one patient who may not be that old but was extremely frail coming into the hospital. I have no financial disclosures. However, I will say I did not define what is elderly. And so if you fall into a category, please do not get angry with me. And then I also want to say I probably am going to talk about something today that you are not comfortable talking about. And I'm sorry about that, but I'm kind of not sorry, because these are things that we as physicians and as people in general need to think about. And so I hope to give you all some skills and some ideas of things you can do. So I could have talked for hours on frailty in the trauma population and burn population. I've done a lot of research, and there's a lot of research that has been done in this area. But given the breadth of specialties, I thought it better to just focus on reviewing what frailty is, reviewing frailty scales that are out there. I'm going to get on my soapbox for a few minutes in the middle about advanced directives, and then we'll end with a little bit about futility. So, as Dr. Farmer stated, our patients, except for hers, are not getting any younger. By the time we reach 2050, 25% of the population will be over the age of 65. And in the year 2030 will be the first time that the people aged 65 and older outnumber children in this country, which are kind of startling statistics. And we will only see our patient population age as time goes on as well. So what is frailty? Well, I think we can all agree that a patient's chronological age doesn't necessarily tell us about their functional status. And so it's thought that frailty is present in about 10 to 20% of the population that's over the age of 65, and in some amount of the population that's even below the age of 65, as we saw in our second case today. Why does it matter? Why do we care if a patient's frail? Well, studies have been done that show that frailty increases your risk of falls, it increases your risk of disability, delirium, cognitive decline, iatrogenic complications, social withdrawal, and death. And most people kind of agree on a definition that reads something like this, right? That talks about age-related, multidimensional state of decreased physiologic reserve, diminished resiliency, loss of adaptive capacity, and increased vulnerability to stressors. It is generally conceptualized as a pre-disability state, so it's generally thought of what comes before a person is truly disabled, although there are more and more scales that are combining it into a single, lumping it with disability. The question becomes on how do you measure frailty, and this has been a complex problem that I will say the punchline of this is that we don't have an answer yet. So one way of looking at it is phenotypic frailty. This is looking at a biologic syndrome of decreased reserve that leads to declines in systems. And so there's lots of things that go in or come out from biological driven frailty: the weight loss, decrease in physical activity, muscle strength decline, decrease in walking speed, and then just patients' overall energy level, what they're able to do. Some of the frailty scales that we'll talk about measure frailty in a phenotypic frailty manner. In particular, the phenotype of frailty, which is probably the most popular in the geriatrics group, and looking at a couple of other single-item surrogates and the frail scale. The other way of looking at it is deficit-driven frailty. And so this looks at it as an age-associated vulnerability that you accumulate deficits to reach. So some of them can be medical deficits, some of them social deficits, some of them can be other individual health problems. And it's thought that people accumulate deficits at a level of about 3% per year. These are then measured as a frailty index, and so you look at the number of deficits that are measured, how many are present divided by how many are measured, and this gives you an index of what their frailty is. And again, there are several examples that I will talk about today that fall into the deficit-driven frailty model. So some single surrogate things that you can do quickly and easy with your patients, especially in an outpatient setting, but become more difficult in my patient population, the trauma patient population, are single item surrogate assessments. And these are thought to be more screening tools. So this is slow gait speed. So you ask a patient to walk 5 meters and you time them. And this has been shown to be a predictor of higher mortality and major morbidity following procedures, elective procedures. And then the other is the get up and go score of greater than 15 seconds. And so what this is the ability to stand up from a chair, walk 10 feet, turn around, walk back, and sit down in the chair again. And again, this has been found to be both sensitive and specific for identifying frailty. However, it doesn't have the full sensitivity and specificity of some of the full assessment tools. And so most people envision these as more screening exams for people who you may want to do further workup on. Another screening exam is the Frail scale. So it looks at fatigue, resistance, which is the ability to climb a flight of stairs, ambulation, which is the ability to walk a block, and if you have greater than 5 illnesses, and loss of weight greater than 5%. If you have a 0 on this, you're considered robust. A 1 to 2 is considered pre-frail, and greater than 3 is considered frail. And again, this was created as thought it would be a less than 5-minute screening tool for people who may need further testing or workup. So then we get to like the full frailty scores. And this is why this is such a difficult problem, is because there are over 70 tools that have been created to measure frailty. And most of them have been validated in a single patient population. So they've been designed for inpatient medicine or outpatient medicine or family medicine or trauma or emergency general surgery. And they have not been tested across populations, and they haven't been tested against each other. So we have no gold standard at this point as to what is the best way to measure frail. One of my colleagues in the burn world, Herb Phelan, likes to say, you know it when you see it, which one of the scales is essentially that. But we'll get to that. There are 3 types of scales. There's the subjective, the objective, and the mixed. So the subjective are very popular, and this one was developed in 1994. And it looks at 4 domains. So it looks at the physical functioning, their nutritional functioning, their social or cognitive functioning, and then sensory problems. And it's scored on a 1 to 4 scale, 1 being no difficulty, 4 being extreme difficulty in doing each of these tasks. And they had to have a score of at least 3 in 1 out of the items to be labeled as frail. And they were frail if they had it in 2 domains. So you became at risk if you had 1 item that was greater than 3 in 1 of the domains, and then if you had 2 domains that were affected, you were constituted as frail. And these found that frailty was associated with reduced day-to-day activities, social relationships, and decreased mental health. The pros of this scale itself is it's relatively short and easy to do, but and no extra tests or training are needed, and that will come into play in some of the other scales we'll just talk about, is that there's other knowledge that you need to have to do them. But the problem is this is a completely subjective scale. So many studies that you'll see come out of the Canadian study on health and aging. And even a lot of the scales that were produced, like so if you hear about the Trauma-Specific Frailty Index or the Emergency General Surgery Frailty Index, they all harken back to this scale. And so the Canadian Study on Health and Aging was a 5-year prospective cohort study that looked at over 10,000 Canadian citizens that were 65 and older. And the hope was to describe the development of dementia and the need for institutionalization or skilled nursing facility placement. And so this led to a rules-based definition and then the creation of a frailty index and eventually a clinical frailty score. So the rules-based definition basically determined frailty on three main things. So bladder and bowel incontinence was a big one for them for frailty. Needing assistance with mobilities or ADLs, cognitive impairment with no dimension, or were the other things that kind of increased your level of frailty throughout this. From this, they developed the CSSJ Frailty Index, which is 70 items. So in the course of most people's clinic visits, this is not practical, right? To try and go through 70 different items while you're also trying to assess someone's blood pressure and their diabetes and their other medical problems. And, oh yeah, you have 15 minutes to get it done, right? So this was a good starting point, and it did a reasonable job of predicting frailty, but it's not practical. So they then, in 1996, took a little over 2,000 patients from the original group who were still free of dementia, and they re-examined them using a clinical frailty score, which I'll discuss on the next slide. And then they also used other measures of dementia. And then they validated again in 2001 with another 1,200 patients. So this is the Canadian Study on Health and Aging's clinical frailty score. And this is a clinical opinion scale. So this is where I said we would get to the one where it was, I know it when I see it. This is kind of this one. There are some things you have to meet to be in each group, but a lot of it is your clinical opinion of the patient. And so 1 is very fit. 3 is anyone with a comorbid illness. 4 is if that comorbidity slows you down at all. And then 5, 6, and 7 are varying levels of dependence on other people for your activities of daily living. But they found this to be really effective. And this is a scale that I've used in a lot of my research, and we found it to be very effective too at predicting death and discharge to a skilled nursing facility following burn and trauma injury. So the increased clinical frailty scores were associated with increased mortality and increased institutionalization as they were dealing with an outpatient population. The pros of this scale in general are the fact that, again, you don't have a lot of extra tests. It can be long if you use the full index. Is one con to it, though. And it's a clinical opinion score, so it's very effective. But again, it kind of maybe does prove the point that you know it when you see it. And so this is one option. So then there's the complete opposite of this, right, which is the I don't trust anything until I see it with numbers. And so these are your objective scales. So this is the modified physical performance test. It takes 9 different skills. It's a little bit small, but one is a book lift, taking off a coat, picking up a penny, standing up from a chair, doing a 360 turn, a 50-foot walk, a flight of stairs, 4 flights of stairs, and then a Romberg test. Its maximum score is 36, 4 points per item. And as you can see at the bottom, there's breakdown of not frail, mildly frail, moderately frail. And they found that in this study, they found that no one of these items did better than all 9 of them together. And again, it's great because it's an objective measure. You have numbers to go with all of these. But it takes time and training to administer. And the other problem is it only takes into account physical frailty. So it doesn't look at mental health at all. It doesn't look at social interaction and the effect that has on people's well-being and their outcomes. So it's a good test, but it has some failings as well. And then this was another study from 1995 that kind of takes the same thing but makes it a little shorter. And so it basically looks at your ability to stand up from a chair. And if you're able to do that, then you do a rapid gait test. And it determines your risk for frailty. This was tested in 1,000 community living adults, 72 years of age and older, and was looking at their people who are independent of doing their ADLs, and found that if you could do both of these, your risk was low of developing problems, and if you couldn't, it was high. And again, you have to have people trained to administer this, and then all these patients in this setting had cognitive delay, or cognitive dysfunction from dementia. And so it's unclear whether or not this is applicable to other groups, and as I said, especially looking at what I have in the burn and trauma population, there are so many other factors that could influence a patient's ability to stand up for a chair. Their fractured femur could very well impact their ability to do this. And so then there's the mixed instruments. And so this is a group of instruments that tried to combine both objective and subjective measures in some meaningful way. And so this first one basically it divided things into people there were frail attributes and not frail attributes, or what they called vigorous attributes. And it's a little bit complicated, but so basically it looked at age, gait, walking. It did take into mental health, so depression, and then strength assessments in both the knees and shoulders. And then it looked at your cognitive abilities as well. And so it found frailty to be if you had less than 1 vigorous and more than 4 frail attributes. This looked at incidents of falling follow-up, and found that in the frail group, 52% of patients had a fall, where in the vigorous group, only 17% had a fall following their initial testing. However, there were still 22% of the vigorous patients who had falls. And so it obviously can somewhat delineate the people who are going to potentially run into problems, but it's not perfect. And again, it's objective and subjective, which is nice, but it's a relatively small number of items, and again, requires participation and ability to move and do the strength and knee exercises to conduct. The next one was talking about the phenotype of frailty. As I said, this is the most widely used in the geriatric population. And so it has a frailty criteria of what it calls shrinking, which is weight loss, weakness, which measures grip strength, and you're considered frail if you're in the lowest 20% of the population based on sex and BMI. Exhaustion, which is self-reported exhaustion. Slowness, which is walking speed over 15 feet in the lowest 20%. And then low activities, which is looking at your number of kilocalories expended per week. And again, widely tested, found to be useful in a general medicine outpatient population. It requires a handheld dynamometer and a stopwatch. And you also have to know the norms, right? So you have to keep in your head, like, what is the lowest 20% for this person's age and sex and BMI? And those are things that are not necessarily readily available as we run around the hospital taking care of our patients. Do you need to get up here? Okay, thanks. And then there's the Edmonton Frail Scale, which is, again, out of our neighbors to the north in Edmonton, that, again, looks at 8 or 9 different factors: cognition, general health status, mood, continence, and functional performance. And it combines objective measures. It includes cognition. It doesn't require any of the norms that some of the other tests do, but it takes a little more time to administer. I haven't personally used this one, but I think this is one of the ones that I think would be very useful, because I think it kind of has the both. It kind of balances your pros and cons. It takes a little bit more time, but it's, I think, very reasonable. And then finally, I included this just because it's another one that is used in kind of the world that I work in, which is the Trauma-Specific Frailty Index. And it cuts down on the number of items. It's only 15 items. It includes some comorbidities. It includes some attitude and mood questions, as well as daily activities and ADLs. I think the problematic one for this is this. So it gives you a point if you have an albumin greater than 3, and you lose a point if you have an albumin less than 3, but that means you have to measure an albumin. And so while in our trauma population, it's probably reasonably frequent that we get an albumin on them, But in an outpatient setting, or if you're wanting to follow these people forward to see what their frailty does, you're not always going to have that marker. So my take-home points about frailty are that there are a multitude of measures, and none of them have really been tested against each other, and they've all been kind of found to predict outcomes and mortality. Few have tested the same measure across different populations, and then even fewer have looked at them against each other. So no one has taken the Edmonton scale and put it up against the Canadian Study on Health and Aging scale and seen which performs better at predicting mortality or discharge to a SNF. And each scale has its own pros and cons, and so it's not yet clear to me or to, I think, anyone which will be our gold standard for looking at frailty. And I think there are many people who aren't really pushing for this, because literally within the last month, a paper has been published on the Burn Frailty Index, which is very similar to the Trauma-Specific Frailty Index, which is very similar to the EGS Frailty Index. But it kind of makes it so you can't look across broad populations. And I think this is something that's affecting all of us. And so I think we probably should start to work towards trying to find a scale that can be used more universally. It's my own personal opinion. All right, so now a little bit of an interlude. And this is where I'm going to get on my soapbox before Christmas, and you all disperse and go see your families. So a little bit about me first. I was born in Findlay, Ohio. I spent a couple years, I spent a couple years in Naperville as third, fourth, and fifth grader. So before my family moved back to Springboro, Ohio, which is in the southwest corner, and I graduated from Springboro High School in 1998 in a class of 190 people and hadn't seen much, but I was very much itching to get back to the city. And so I went to Loyola for undergrad, and what you may not know about Loyola is it's a Jesuit university, and so our core curriculum was like 120 credits. Like, I took 3 philosophy classes and 3 theology classes. I interestingly took a course entitled Hermits, Virgins, and Martyrs, which is about the saints. Anyway, but I also took medical ethics, and this kind of, for me, started my interest in looking at ethical issues. And so following that, I went to the University of Chicago, and after my first year as a medical student, I did a research project, and it was looking at parents' reactions to participating in interviews about end-of-life decision-making in the PICU. And this is me before I got married. Dr. Kugler, who was the PICU attending, this was actually a joint paper between Northwestern and the University of Chicago, which anyone who knows the Chicago landscape is very unusual that we would participate in anything together. And so I spent my summer after my first year of medical school riding the L back and forth between the University of Chicago's PICU and Northwestern's PICU to interview parents of children who were in the PICU for greater than 24 hours. And it was an interview that basically looked at in what situations would you consider withholding care from your child, and in what situations would you consider withdrawing care from your child. And in some of these cases, this was a very theoretical thing for these people. This was the spine patient who was just in the PICU overnight. It was the trauma patient. And in a lot of cases, I interviewed several families of children with SMA, where this was a very real thoughts that they had gone through their head of what were they willing to do, and where were they willing to go. And Dr. Kugler, who she said when she first met me, she didn't think I would make it through this summer project. She thought I was too soft and that I would never be able to have these discussions with families, but I proved her wrong. And so this led to kind of my one of my personal passions, which is advanced directives and end-of-life planning, and thinking about what the patient wants. So this is the interactive portion. So how many of you in this room have ideas about therapies that you would or would not accept? So who in this room says, in no way, shape, or form am I ever having a Whipple? or if I have a 90% burn, like, forget about it, right? All right, so a fair number of hands went up in the room of people who have things that they wouldn't accept. And then and this kind of goes the same thing, but it's have conditions that they definitely would not want to treat, right? Or definitely would want to treat, right? Probably a large number of the people in this room. And how many people in this room know what their own end-of-life preferences are, right? All right, now we come to the question. How many of you have discussed these with your family? All right, good. I'm happy. A lot of people. The people who aren't raising your hands for this one, you need to think about what you're going to do over Christmas. But more importantly, especially for people in this room, and especially I'm looking at this column right here largely, how many of you know what your family's wishes are, right? How many of you have had these discussions with your family and know what they would want in various situations? Good. I'm glad I see lots of hands because that's great. Anyone whose hand didn't go up and is feeling like, oh my, I don't know these things, maybe not on Christmas Day, but sometime when you're with your family. Because I will tell you a little bit of the story of so this is my family, or part of it. My dog Daisy, my husband Robert, my son Reese. And we have had these discussions. And my husband is not especially comfortable talking about them, but I have managed to pry from him what he would want. And we've actually, my son has multiple medical problems, and so we've actually had to think about what our line is for him and what we would do. But I hadn't had this discussion with my family, with my parents. And so actually this was our trip to Oregon this summer, and I went and I had sat my mom and dad down separately, and I was actually really surprised at what their preferences were. One, my mom I kind of knew, and I was correct, but my dad was very different than what I thought he was going to be in his preferences. And so now I know it's something that his are going to be much harder for me to go forward with. He has much more. He wants this trach and peg, and I don't know that I can go through with it. But I know, and I know what his wishes are. And they all now know what mine are too, because I think again, it's important for more than one person to know too what you would want. But they're important, and find the time. I said, maybe not on Christmas morning, maybe this isn't the most jolly discussion to have, but find a time to discuss with your family what their wishes would be and what your wishes are. Because I think that going forward, these are things that, are important, and people aren't getting any younger, as we already talked about. All right, so now on to the equally cheery topic of futility.
Stand up and scratch or something.
Yeah, exactly. So I'm going to give you a little bit of a case. 75-year-old guy smoking on his home oxygen for his COPD. He was brought in by EMS after a neighbor saw smoke and heard screams, and they found him on fire in his wheelchair. He was extricated and extinguished, and 911 was called. He is intubated. He is cachectic. He is 5'2" and 75 pounds. He has a sacral decubitus ulcer that is noted. Remnants of a melted diaper were found on him, and he is still wearing a medical bracelet or medical wristband from his previous hospitalization from 3 weeks before. He has a 56% total biosurface area burn with mostly partial and full thickness, but he does have 4th-degree burns on his legs. His chaplain has found 2 adult children who will arrive in approximately 9 hours. He has a modified Bow score of 131, and these are his burned areas. So, again, more at least raising our hands if nothing else. So who thinks I should admit him to the burn unit, do best guys escharotomies, start a resuscitation, and when I talk to the family, just lay out the options for them and say, hey, you have lots of choices to make, what should you do? Please, no one pick that one. Who thinks I should admit him to the burn unit, do the bedside escharotomies, start the resuscitation, and then when they get here, have a discussion that kind of indicates that you think that this patient should probably be comfort care. or whatever you think should be done, but give them some opinion of what you think should happen. And then, who thinks you should institute comfort care immediately in the emergency room? And when the family arrives, explain that there's nothing to be done. He's being made comfortable and is expected to pass. Yeah. So the question that comes into this is what does old age look like? Is this old age, right? For some people it is. Or is this what it looks like? And I think this one is very telling. So these two women are approximately the same age. And I'll just put that out there, as Dr. Farmer said, get up and stretch or take meat out of your diet, whatever you want, but which life are you designing? Which are you headed towards? And so this is not always clear, and I think frailty does probably play a role in our futility discussions. But more what I'm going to talk about today is the importance of early goal setting, and what are we trying to accomplish. So goal setting is jointly creating a treatment plan that consists of the patient's values, goals, and preferences. Many physicians, rightly or wrongly, assume that survival is the goal. So this is where we kind of get in our own way. And this may or may not be the case for this patient. We have a patient currently who family's very reasonable that survival may not be her goal. And we are okay with that. And then physicians are also often uncomfortable discussing limitations of care. This is something we don't like to do. It's not why most of us went to medical school, was to discuss limitations of care. And we often wait until things aren't going well till we have these discussions. And I'm going to urge you through some of the things I'm going to talk about now, that is not the time to start having these discussions. The time to start having discussions about patients' goals is long before you're in a crisis moment. So when the prognosis is poor, there's been studies that show that families consciously or unconsciously misunderstand prognostic information. And multiple studies suggest that the sicker the patient is, the less likely patients are to understand the prognosis. And understand what is going on and what is being asked of them. And so this is why the moment of crisis is not necessarily the time to start these goals of care discussions. Barriers that are put into place that prevent our ability to set these goals are focusing on the small details rather than the big picture. And the families, start to rely on their own gut instinct and their personal beliefs about the patient. So this is why I got on my soapbox before this, is because, when you're in this situation and it's your family member, I want you to know what it is, not what you think it is that the patient that they would want. Patients often and their families often seek information from news and other sources, and they go online and they Google things and they find that one patient who did great after whatever has happened to them. And then they avoid or outright disbelieve the prognostic information. And this study in Journal of Paramedicine found that these are more common when you don't discuss goals early in a hospitalization. So when you're at a moment of crisis, it's even more likely that they're going to not believe what you're telling them. And so what do we do about this? How do we go forward? And so far I've been talking about what the information gets imparted and how we impart it, but there's a lot of actually funding now looking at how it's imparted. And there's this great study from the Journal of American Geriatric Society that looks at a way of talking about to families. And that's kind of what I want to hopefully you all can take away from this, is that this is one option for a way of setting up conversations with families about potentially poor prognosis situations. And it's called the best case, worst case scenario. And I don't know if many of you have read about it or seen it before, but they actually, I can either forward you the items or the articles, but you can actually go online, and if you search for this, they have a whole training kit that you can download for free on how to do this. And there's some videos on YouTube on it as well. And so basically what it does is you want to construct a best case, worst case framework. So you sit down with the family with a pen and paper, and you create a vertical line that represents a different treatment choice, and there can be more than one alternative. So it can be, surgery versus no surgery. It can be surgery versus lesser surgery. You can even have 4 different options. The star at the top represents your best case scenario. The square at the bottom is your worst case scenario. And you put an oval on the line where you think is the most likely scenario to happen. But before you start discussing outcomes, it's important to, as they put in the training, to break the bad news, right? So you need to talk to very openly that you have bad news and that this is not an easy decision, and that there are a couple of options and each of them has potential outcomes. So you want to tell a story about what the patient's life would look like for each of these options. And I think what I love about this is I think if you start to think about it beforehand, I think it really crystallizes for you before you even talk to the family what you're asking of them and what their life potentially will look like. So you want to be tangible about the long-term benefits and complications of the proposed treatments. You want to have the short-term implications as well, what it's going to mean for them, and then what it looks like in a larger context of the patient's overall health. And you want to tell them, again, the story of the worst-case scenario. So what's a reasonable worst long-term outcome? What's the reasonable worst short-term outcome? Many families believe death in the operating room is the worst-case scenario. I think everyone in this room knows that that's probably not necessarily the case in most situations. The worst-case scenario is, death in the ICU after weeks of complications. And then you want to write on the paper so that the family has this to take, to think about afterwards and keep notes. And you want to repeat the process for each treatment that you're talking about. What's the best thing that can happen and what that looks like, short-term, long-term? What's the worst thing that can happen, short-term, long-term? And where you think that they're going to lie on this continuum. And this is just an example that's in the paper that looks at surgery versus supportive care. And so it points out that, for surgery, best case scenario is you have a long surgery, long ICU stay, and you're headed to a nursing home after this. Worst case scenario is long surgery, complications in the ICU, and that you die in the ICU having never really regained any function. And then the most likely situation on the surgery side is that in this case, whatever they were discussing, they thought was closer to the worst case scenario, that you would have 2 to 6 weeks in the ICU and most likely succumb to something related to this incident in 2 to 3 months. Supportive care, as you can see, the line is shorter because if you go the supportive route, you may not have as much time, but you may have time to say goodbye to your family in a more controlled setting is the best case scenario with adequate pain control. And depending on what the case is, you may be able to go home, right? Worst case scenario is death is imminent and you will die quickly. And the most likely scenario is probably someplace between this. And so I actually have a kind of a funny story that when I was at the University of Iowa, I had learned about this and I was trying to use it in my patient population. And so I had a 95-year-old woman with a cervical spine fracture who neurosurgery was kind of saying, well, we could fix it, we could not. And so we sat down with the family and kind of went through these best case, worst case scenarios. And they ended up deciding to go with comfort care. And so we took her out of her collar, we let her eat and drink, and she went up to the hospice floor. And 7 months later, I get a phone call from her family, or a message from them saying that she was doing great at home. She had graduated from hospice. And, as long as she didn't fall again, she was doing just fine. She was 95 years old, so, she was tough. But so, sometimes I will say even when we go down this road, we may not know what this best case scenario is. Like, I don't know that I ever would have told them that their best case scenario was that 7 months later she would be doing just fine at home. But, it happens every once in a while. But they were very thankful, because I really do believe if we had gone down the road of immobilizing this woman's spine and putting her through a spine surgery, that the outcome would have been very different. And so, we're trying to find the delineation between good and better, and trying to stay on the right side of it, right? So not, the enemy of good is better, and but trying to find the place in the middle that we can take care of patients that both amplifies their goals, but also doesn't put us in a position that we're not comfortable with. And so what is futility? At its most basic level, it's, will the outcome of an intervention be what the patient wants? Will it be what we're striving to get to? But this requires knowing things about the patient and their values and goals and preferences. And so I think these goal-setting meetings are important. So returning to our case, kind of just going back over everything. So this is a sick guy. He's obviously not doing well. He's been in a wheelchair. He has a diaper on. He has an old medical bracelet on, and he's got 3rd and 4th degree burns with a modified Bow score of 131. So what does that mean? So this is looking at geriatric mortality by Bow score, and you can see it rises up pretty quickly. This is where 90% mortality line is, and this is where our patient is. So he's in this 130 to 139 category. So without knowing anything else about him, this is kind of where he's sitting at his greater 90% mortality. All right, so final vote. What should I do? Should I admit him and just forge ahead and ask the family, what do you want me to do? Should I admit him, forge ahead, and when the family gets here, say, look, I don't think this is going the way we want it to? Or should I just make this patient comfortable right now? Anyone changing their votes? It's still hard, right? So this is what I did. So I actually chose, based on his history and what I knew about him, to make him comfort care. The family did arrive before he passed and got to spend some time with him. And we're not upset about this decision, based on the medical problems and some other things that I haven't fully presented here. So this is a paper out of JAMA that talks about medical futility in end-of-life care, and I think it's a really great paper. I also highly recommend this one. And it also starts to look into of what happens when the family doesn't agree with you. So what happens when you think that the care is futile and the family doesn't agree? And basically, it goes down multiple decision points where you, at first, if you don't agree, you try and get them to another accepting facility that potentially will be able to care for them in a way that's more to their liking. And then you have joint decision-making meetings. You involve consultants. You bring in the ethics committee. You attempt to transfer care within your institution if you can't get them to another institution. And then you, sorry, I got this backwards. You attempt to transfer within your institution to someone who is more willing to, doesn't believe that their care is futile, and then transfer potentially to another institution. And if that's not possible, there is some arguments for ceasing what you deem futile care, even if the family doesn't agree with you. And this has been, and I'm going to talk through a case quickly, but this has been tested in the courts. So there is some legal precedent for you not having to carry on doing care that you don't believe is going to lead you anywhere. And so the point here is that by ethics standards, the intervention in question need not be provided, although legal ramifications of this course of action are uncertain. And I still would say they're uncertain, but there was a case at Mass Gen. It's a 1995 case. 72-year-old frail woman, multiple comorbidities, including Parkinson's, fell and broke her hip. Her daughter lived with her and was her primary caretaker. They actually initially refused medical treatment, and she actually decompensated at home. And so the daughter called for an ambulance because the mother was gasping for air. She underwent a hip repair on post-operative day 8. And then postoperative day 1 following that, or post-injury day 8, and postoperative day 1 of that was having seizures that took about 5 days to get controlled, which left her unresponsive and posturing. So this happened over about the course, she only improved, over the course of a month, her mental status or her neuro exam improved to only grimacing and withdrawal from painful stimuli. Neurology was consulted and felt that her prognosis was dismal. The ICU attending recommended making the patient DNR at this time. The daughter refused, saying that her mother wanted everything possible to save her life regardless of the cost. And on hospital day 28, they got an ethics consult, which in the end, the ethics consult felt that CPR was inappropriate in this case, that the family's confusion, anguish, and misinformation, denial, and distress do not justify mistreating the patient. So the ICU attending described the situation as futile. The daughter demanded full code status, as she believed her mother would recover fully. She refused to discuss the situation further, stormed out after threatening the life of the ICU doctor and verbally berating the ICU staff. Ethics was reconsulted and again felt that CPR would be unethical. The ICU doctor documented a week of trying to contact the family. Caretaker daughter refused to speak to him. Second daughter referred him to her attorney. They looked for another hospital who would be willing to take this patient on for transfer, but found that this was unable to be done at this time. And he notified that he planned to wean the vent with no plans to return to reintubate her if she failed. She died 2 days after being off the vent for 2 days, and the family immediately sued. And the jury found that the patient would have wanted CPR, but that this was constituted futile care based on the ethics and notes from the ICU physician and the neurology team, and found no negligence for any of the providers. And family said that they would appeal, but actually have never followed through with that. And so with geriatric burns and geriatric trauma and all of our geriatric patients, early goal setting is vital. So we need to know early what people's desires and wishes and preferences are. And we need to, I think, very early lay out for them what the best case scenario of their treatment looks like and what the worst case scenario of their treatment looks like so they can make an informed decision. I think this best case, worst case framework can be useful as we go forward to look at how we talk to families. And then just to understand that you are not necessarily obligated to provide what you consider futile care. Thank you.
Well, despite the holiday, what a really great overview and practical approach to giving us some real tools to think about, in addition to talking to our families, but also to think about how we take care of patients. We have a minute or two for some questions, so I see a few. Let's start.
Going back to your experience, talking mostly to the older population, but what advice do you have for surgery? When do you have those discussions with complex, pediatric patients? Like, how do you go about that? What do you suggest doing it?
I would. So the results of that paper are actually not about the discussions about the end-of-life care, but it's about the parents' reactions to it, and it's a qualitative paper on how they felt having these discussions, and most of them were not bothered by it. Either they had thought about these things before and were found it helpful to have someone to talk to about them, or in a lot of cases when it was like the trauma patients who had never thought about it before, they still weren't upset by it. So it didn't bother them to discuss situations where what they would consider doing in the situations. And I think there's no harm to starting, even in the pediatric patients, starting these discussions earlier rather than later about what is a acceptable outcome for them.
Dr. Rosen.
Hey, that was a great talk, and thank you for bringing it up. If only just to make us all think about, how to take care of our loved ones and ourselves in the most appropriate way. And I just wanted to comment because, and congratulate you in being really courageous in taking care of that patient, because I think that in the shift from paternalistic medicine to really trying to shift our view towards stressing patient autonomy, we've done something very cruel to the patients, and we see this all the time, where your first option is the one that's given to the patients, where the doctors abdicate their responsibility to really provide care and do the most merciful thing in my mind. And I don't think it's appropriate nor kind to give your patients the options and have them decide. And I know that that's sort of the ultimate patient autonomy part. Most of the time, people aren't looking for that, and it's especially when you're asking them to make end-of-life decisions that they haven't necessarily thought about not just their grandmother or maybe their wife or husband or their child. I think it's cruel, but it takes a lot of courage to help people and guide them through these really, really difficult decisions. And it takes a lot of courage to say this is futile, and I'm going to give this patient the care that I think that they need, and we're making that last option. I think you should be congratulated for that. That's really hard.
There's another interesting twist on this that someone brought up to me not too long ago, but in the day before there was Medicare, decisions were made a lot differently about grandma if you were paying for that ICU bill.
That's right.
Or you were providing, it's just real, or you were providing the in-home care. And so we've made these decisions a lot more distant from us. It's theoretical. They live somewhere else. They're in an ICU in some other town. And of course you want everything done for grandma. But if somebody said, okay, for $100,000 you can have, 2 more weeks, then you've got a family and you've got your kids, and it's just very interesting how it has really shifted the discussion. Dr. Palmieri.
In pediatrics, there really isn't a frailty scale, is there?
No.
We've talked about this.
Yeah, we have.
You presented types of frailty scales, performance scales versus comorbidity scales. What would you think would be a starting place for pediatric scale?
So I think starting place for pediatric scale probably has to do with underlying medical conditions, because I think I think that's probably the case in adult frailty as well. That I think a lot of what we're actually looking at frailty is looking at their comorbidities and how well they're controlled, although I think more goes into it in both situations. But I think the starting place is probably looking at underlying medical conditions. And I think in pediatrics, almost even more than the adult population, then comes the social support. And what does the family unit look like? What's available to the child?
Complex. All right. With that, happy holidays, everyone. Talk to your parents.